Yeah, thank you very much, all the three speakers who really have given us some effort that has been made in these three countries as far as the viral load monitoring is concerned. And I really like the fact that we need to, upscale the education of our healthcare providers, but particularly the patients themselves. And what I see and as a challenge even in South Africa is that we don't empower our patients well so that they can come to a point where they can demand services. So we want to reach a point where a patient will know that at 6 months, when you taken my blood, you need to give me a result, and they can demand it. And I'm sure maybe that will help in terms of reaching our 1990 target as far as the viral load is concerned. So we can take some questions. Yeah, there's one here. I think we still have a bit of time. Let's start from, yes, sir.
Guido Ferrari, Duke University. I am impressed by the progress in the past 4 years across the continent. It's remarkable. But I'm a little worried about the number of platforms. 19 platforms in one country. I can understand the needs for technology, and one platform is good for a small lab and a big lab, but the sustainability of reagents and monitoring the quality of all of those. So this is not just one question for one of you, it's a question for all three countries. How are you dealing with that amount, and how are you planning to scale this down?
Thank you. Maybe let's just take 3 questions, and then our partners can respond. There's a gentleman there. Yes, please, number 1.
Hello, thank you. My name is Useni. A question is more about the Nigerian experience. Yes, of course, we need to increase coverage for viral load, but the main objective of viral load is to identify the failed one and able to switch them as early as possible. So I miss a bit what are the impact on that, and what were your challenges? Thank you.
Thank you very much. Please introduce yourself and maybe just direct the question to a country that you want to. Yeah, a gentleman in the red.
My name is Akoku. I'm from Côte d'Ivoire. Thank you so much for your presentations. They were very interesting. And I must say I was very excited to know the good work that you are doing in your various countries. I just wanted to find out from the presenter from Zambia and Kenya, is your laboratory data for viral load linked to your clinical data, which is like the EMRs? And do you have like challenges to data quality with respect to viral load data? And in all of the 3 countries, we saw that viral load suppression among children was relatively low compared to adults. So in your countries, have you guys started trying to understand some of the factors, perhaps sociocultural, that could be responsible for the low viral suppression, and if certain actions have been taken? Thank you.
Thank you very much. Let's just get some answers. Prof, we can start from you, Zambia.
So for the number of equipment and scaling down, what we had to do is, and I think this may be across many other countries as well, is we have a challenge of transport systems. So we had to cost how much it would take for one specimen from one region to go to the 3 large testing facilities, as opposed to placement of an equipment in each of the regions. And it came out cheaper by placing an equipment in each of those regions. And instead of having, that's why we moved from outright purchase. Outright purchase was going to be more expensive, and also maintenance and sustainability was going to be difficult for our country. So with the negotiations of having the vendor be able to place the equipment, then all the maintenance is on the vendor. Then we are only responsible for having the numbers and also the reagents. So that way it was easier, and it was also much cheaper and more sustainable. So we had to look at those two aspects. But even besides that, when you look at even the placement, still we are having challenges. We may have certain areas that may be 600 kilometers away from one testing facility. So even those, they need the near point of care, and those, they have low volumes as well. So we've tried to use both mechanisms. We found that it was cheaper having these large throughput equipment in each region as opposed to 3 regions at the whole country.
Okay. Kenya?
I just want to add to what Prof has said. Our situation is similar, like in Zambia, but just in terms of quality, all the testing labs are enrolled in EQA schemes for all of them doing viral load, which is both inter-lab and also external with CDC Atlanta, so they're able to ensure quality at all times. In terms of sustainability, what we've done is have continuous price negotiations with the various suppliers. And currently for viral load, we have actually all-inclusive cost, which caters for the consumables, the reagents, the equipment, service contracts, and so forth, and which has really come down to maybe around $9 per test. So that has also aided us to ensure that even if the donor leaves, then it would be much easier for the government to take over the cost. So in terms of scale down, I don't think we'll scale down the equipment. Maybe we'll decommission the ones which are no longer viable in the system and continuously look at the high throughput equipment that are coming up. There was another question around whether our viral load data is linked to clinical data. And just to say that we have EMRs commissioned in almost all the high volume facilities, about 800 facilities, and about 700,000 of our patients are seen within the EMRs. Both point of care EMRs and others, you have to upload the data after seeing the patient. So what is currently going on is that we are updating our EMRs to be able to capture both the viral load data, because there's already a database for that. So there's an interoperability layer that is being created to be able to merge the two systems. In terms of data quality, yes, we have some data quality issues which are continuously being worked on, especially regarding of the 1.2 million tests in terms of incomplete data in the LRFs, in the lab request forms, which sometimes you're not able to tell, was this a viral load test for purposes of routine test? Was it a repeat test? Was it a baseline viral load test for an infant where age is missing, and so forth, which is a continuous issue that we work on. And then in terms of viral suppression in children, which has continuously been lower, though we are working very hard towards viral suppression of 80% in our children, because that has been traditionally between 60 to 70%. And one of the things, we recently did a viral load assessment in the children, and it's multifactorial. There are issues of caregiver, there are facility level issues, there are caregiver issues, there are issues of the drugs themselves, the palatability, for example, of the Kaletra syrup, which are all concerning in terms of adherence. And those are some of the things we are looking at, but also looking towards WHO getting us new regimens for children.
So basically in Nigeria, we've consolidated our platforms into just 2 platforms. And like she said, basically quality assurance is also maintained for all these platforms. We also didn't want to have monopoly of just one vendor or supplier or equipment manufacturer. The importance of viral load coverage versus suppression, I think it's the case of the chicken or the egg, which one comes first. If you don't even have the viral load result, how do you even know if the person is suppressed? So you can't even take a decision about suppression if the coverage is low. So I think it's equally important that we scale up first and make sure that there's access to viral load to every person who is on treatment. And then we check the suppression. And we are monitoring suppression and actively managing to make sure every individual is suppressed. Like I said, we have 20 to 30% of individuals who are not suppressed. And there are drug and therapeutic committees whose job it is to review these results, review the issues, and advise and provide adequate support. So there's enhanced support to these individuals for at least 3 months, and then viral load is repeated. So this is what the protocol does. And then I also mentioned the fact that for children and adolescents, the biggest concern is that they are either on the wrong regimen. Like children under 3 are supposed to be on PI-based regimen based on the study that showed that at least 48% of children less than 18 had NNRTI mutations. So the guidelines were revised to recommend that all children less than 3 should be on PI-based regimen. At this point, a lot of children are still not being able to access PI regimen, so we are trying to do an aggressive transition for that. So making sure that there's audit of the regimen that clients are on, and that they are on appropriate regimen, but also for children, making sure they are on appropriate dosage, and that there's adherent support for children and adolescents. I think these are critical issues.
Thank you very much. We still have 5 minutes. Just also to touch on the question that was raised in terms of management of patients. And indeed, the viral load have for clinical management of patients. I think she's spoken about if the viral load is not unsuppressed, if it's the first time that you do it 6 months, then you do adherence support. And of course, if not, then you can switch the patient. So there's a critical need in terms of clinical management of patients, as well as clinical outcomes, to know if the patients are doing well or not. I think they've touched on that. Any other question? There's someone, yeah, let's take that one, then we'll come back to you.
Thank you. Thank you. My name is Isira Molajin in Nigeria. I work for UMB. My question is directed to the Kenyan doctor. Thank you for your presentation. I just want to know the criteria that you use to locate the POC gene expert machines in hard-to-reach areas, and what you mean by hard-to-reach. Because we know in Africa there are some places that are hard to reach, that you don't have power supply, you don't have skilled staff. Please, I'd like to know what the criteria is. Thank you.
Thank you very much. I'll take 2 more questions. Number 2.
My name is Hebziba.
And number 4. Yeah.
Hebziba from Kalombo Teaching Hospital, Central Laboratory. And it goes to Dr. Hadiza. I would like to know how you were able to achieve the reduction in sample rejection.
Number 4.
Good morning. My name is Silibele Mpofu from Zimbabwe. My question goes to Maureen. I wanted to find out, you mentioned something to do with the community ART. Maybe if you could shed some bit of light on how that operates.
Thank you very much. Let's just get the answers. Can start with Maureen.
Okay, so sample rejection. I mentioned initially that if you assess the health facilities at the beginning of this scale-up, you discover there are a lot of gaps in capacity to even collect samples appropriately, process them properly, and storage. So even in the course of transportation, the integrity of samples could be compromised. So what we have tried to do is to look at all these steps and make sure that capacity is built and that that the facilities are equipped with the right kind of gadgets to be able to do sample transportation and storage. So that has significantly impacted on sample rejection. I don't know if...
So the criteria that we use for placement of the near POC was that one, as we said earlier, Kenya is divided into 47 counties. So for the county headquarters, they have access to power, HR access in infrastructure. So, and we already had gene experts that had been placed there for purposes of TB diagnosis since a while back. So we are just using the already placed equipment in those facilities to now, in addition of TB, to do the viral load and EID. So, so one of the criteria was they must be far from the central testing, probably if you are more than 500 kilometers away from your testing lab, then that would be a criteria. And then there is also the issue of sample transport. In some areas, because of the distances, the security issues, then they're not able to transport their samples, or the G4S courier is not able to access those areas, and that was some of the consideration. But in terms of HR capacity, where there was a gene expert equipment, the lab technologies were already adequately trained to be able to handle the viral load and EID. And in addition to that, they are also able to send their positive samples for QA to the National HIV Reference Lab. So there's ongoing quality checks that have been done. In terms of the community ART groups, which I showed earlier, so in a few of the counties where stigma levels are not too high, patients from a particular facility can come together, and they are able to be able to collect their ARVs at community level or do their refills at the community level. And so they could either send one of them to come to the facility to pick the drugs for the rest of the group and take it to the community where they meet. They can do their support group. There's an ART distribution form which they fill in case any of them needs to be referred back to the facility because they have a new symptom or they have new adherence issues. Then they are also identified and referred back by this leader that they have chosen for their community ART group. So this is one of the interventions that we are really trying to push, because we know that 80% of our population, of our PLHIV population on treatment, actually meet the eligibility criteria for long TCAs, and they don't have to come to the facility all the time.
Thank you. Prof, you have a last word before we close?
I think what we just wanted to add on was the hard-to-reach areas, also for the point of care for us. We have just used the same systems for where we have the gene expert for the TB. But also, in addition to that, we have also sourced other more point of gene expert equipment for certain areas where we do not have the gene expert, so that we can also, for those areas which also have a high throughput, where there is high TB rates, so that we do not overload the experts which they have in those facilities.
Okay, thank you very much. I think we're at the end of this session. I would like to thank again Abbvie for the opportunity, and to thank all of you for your time. And maybe just a word of conclusion is that if it's not measured, it cannot be treated. And if it's not recorded, then it cannot be, it's like it's not been done. So thank you very much, and we'll stop from here. Thank you.